Thank you very much for this opportunity. I'm glad we have such a good turnout online. And I'm Pat Culligan, Dr. Culligan, and I'm just going to talk about pelvic floor issues, female pelvic floor issues. So if we have any guys watching, then I won't be talking about anything pertaining to you, just women today. So this is me and my partner, Dr. Saiz. We work here at this building, 1200 East Ridgewood Avenue, which is across from the duck pond. This is our outpatient office, so we do a lot of our patient care in the office, but then we also both surgeons, and so there's a lot of a surgical aspect to a lot of the things we do as well. The field of urogynecology is how I'll introduce myself. So I'm a urogynecologist, and I've been doing just urogynecology since I finished my fellowship in 1999. So over 20 years of just focusing only on women and the female pelvic floor issues. Urogynecology as a specialty is relatively new, probably been around as a formal specialty for around 30 years. But the point is, the reason why it exists is because we're not quite gynecologists, we're not quite urologists, we're sort of a combo. And the things that we mostly treat are something called pelvic organ prolapse, where the organs are trying to fall or bulge out like a hernia through the vagina, or urinary leakage of different kinds, or even if you don't have leakage, having an overactive bladder or having a feeling that you are always having to wonder where the next bathroom is. Those are probably the most common things that we treat. Also, we treat things like fecal incontinence or constipation, that kind of stuff, which all relates back to the pelvic floor. I trained she asked me to describe my training a little bit. I'm from the South. I grew up in the South. I did my medical school in Georgia and my residency in South Carolina. And then I went to Chicago at Northwestern for my fellowship. And then I moved around a little bit until we settled in Jersey. And I got recruited away for a while to run a program at Cornell, which I did for about 5 years. But I recently decided that commute into the city was just too much for me. And I've transitioned back to Jersey to work with my great friend and colleague, Dr. Saiz. And I'm very happy to be here at Valley Hospital. It's been wonderful. The biggest, I guess, hit or insult to the pelvic floor, it comes along with vaginal delivery. So at the time of vaginal delivery, it is a traumatic event for the muscles and the connective tissue and the nerves of the pelvic floor. And people typically heal up just fine afterwards, but then some people don't. And you don't really know who that's going to be until a good bit of time has passed, because the vaginal delivery itself will stretch the nerve supply to the muscles. And then many of you probably experienced this. Maybe if you think back, right after you had a baby for the first month or two, perhaps you felt like the muscles were sort of just dead down there, and you had trouble if you were trying to do a Kegel exercise, if you know what that is, or maybe you didn't feel quite as much as you were feeling before as everything's healing back. But for most women, it all goes back sort of to normal within a period of maybe 2-3 months, sometimes longer. But for other women, there's more sustained damage, and that's where we come in. There's an epidemic of prolapse and incontinence, especially. If the average woman has about a 30% chance of needing surgery to correct prolapse or incontinence in their lifetime. So that's a pretty big chance. 30% of women out there are having these issues and decide to have surgery for it. So let's back up a little bit and talk about the organs. I'm going to bring up a little laser pointer that I can use electronically. So here's the normal anatomy looking in from the side. There's going to be some anatomic stuff today, and I hope that doesn't bother you. And there's even some surgical video. So I'll give you a quick warning before I start on those slides. Here's the urethra where the urine comes out. Here's the vagina leading up to the uterus. And here's the rectum. And the pelvic floor muscles sort of surround all of this in kind of a U shape. And that's where they are. These are the pelvic floor muscles. And they're responsible for really doing a lot of the control and support in the pelvic floor. So there's the uterus, bladder, urethra, vagina, and the rectum. And then that's the group of pelvic floor muscles right there. Without the muscles, we're left with just connective tissue. So in this image, the bladder is transparent, and you can see the urethra and the relationship between the various structures. So the connective tissue is important, but imagine just this stuff holding everything up. It wouldn't work, right? You need those muscles as well. And this is why these are the muscles of the pelvic floor, and so they're filling that gap. Without the muscles, the pelvis would just be sort of like almost like a basketball hoop. Each vaginal delivery has the potential to further weaken the pelvic floor, and sometimes people don't bounce back as well. Like I mentioned, it's a traumatic event. It's a natural, normal, wonderful traumatic event. I've got 3 children, and I believe people should have as many children as they want to, and it's a wonderful blessing. But it can still be damaging, especially to some women, and we don't always know who those women are going to be until the injuries present themselves. The best chance to avoid our office is to learn how to exercise your pelvic floor muscles. So if you watch closely on this video, you'll see that every 10 seconds, the picture changes. And right now it's in a contraction mode, squeezing the pelvic floor. And you can try this on your own. Look at what the muscles are doing and try to think about how you would close or open those muscles. And it's not a big movement. You could be sitting there with anybody. You could be sitting there with, anybody in the world, and they wouldn't know you were doing this. It's a very private exercise. If you're moving other muscle groups that are external, you're not doing it correctly. So squeezing these muscles and exercising those muscles and getting them strong is the best way to avoid coming to our office. So I recommend women, when they're pregnant, do up to 30 or 60 Kegel contractions like this per day, and especially after they deliver, because that's the quickest pathway to returning back to normal. So let's get into some of the conditions that come from a weakened pelvic floor and weakened connective tissue. One of them is urinary incontinence. This aisle should look pretty familiar if you have urinary incontinence. Feminine hygiene products are a gigantic business, and the reason that the aisle takes up the whole aisle in the CVS of the Duane Reade is because there's a huge number of women out there with these problems. And actually, 1/3 of all menstrual pad purchases are actually for urinary incontinence as well. These are the different types of urinary incontinence. There's 3 basic ones, really 2 actually. So there's stress incontinence. That's when a woman leaks urine with coughing, laughing, or sneezing, or jumping jacks, or some sudden movement, and it causes spurt of urine to come out. That's stress incontinence because we're referring to the physical stress of the activity. And then there's urge incontinence, which is when you have that classic key in the lock syndrome, where you're coming home from doing something or coming home from work, and as soon as you get to your door, that's when your bladder tells you better get there, and you might not even make it, and it starts to come out before you can get to the bathroom. And then if you have a combination of the 2, that's called mixed incontinence, and a lot of people, probably most people that I see in my office, have a mixed picture. So the kinds of things that produce the stress incontinence are coughing, laughing, sneezing. Urgency is like, I gotta go right now, I gotta go often, I gotta go frequently, I gotta go a lot of times in the nighttime. And then mixed is just a combo. So let's talk a little bit about the treatments for overactive bladder. The first is fluid management. Some people, it seems like the most healthy thing in the world to drink water, but you can drink too much water. So some people, this interaction happens a lot, where someone will come, and we have a thing, we do a bladder diary. We ask people to write down everything they're drinking. We take a good history about this, and some people are drinking way too much water, and it's a simple fix. They're drinking 64 ounces or more than that of water every day, and they maybe only weigh 100 pounds. That's too much water unless you don't mind being in the bathroom more than once an hour. So I think there's a common misconception that you couldn't possibly drink too much water, but you actually can. Other types of fluid management to think about are coffee, tea, and seltzer and soda. These things can be irritating to the bladder, and they can cause a problem that's not just about how much you drink, but also what you're drinking. That can be a problem. When we run out of success from fluid management and dietary changes, medications are next. There's several types of medications for overactive bladder. that can be very effective. If the medications aren't working out, either because of side effects or because they just didn't work, then we usually go to Botox injections in the bladder, which is an office procedure that's done once every 6 or 9 months. Works very well, with a couple potential downsides that we discuss in detail. And then the final or last line of therapy is something called neuromodulation, which is literally kind of a pacemaker for the bladder nerve that's implanted in the body and sends an electronic message to the nerve that controls the bladder function. So that's a more extreme situation that requires surgery, but we almost never get there. Usually the most significant thing we do in that regard is just Botox injections in the bladder in the office. Yeah, I just thought this was sort of funny. And you have a hard time holding, but I'm going to give you on the next slide something that might help you be able to do what this woman is suggesting. So once you develop your Kegel muscles and you really do know that you're controlling them well, this is a way that you can, the very next time you feel a strong urge and maybe you're not close to a bathroom, try this. Be still, maybe sit down, do 5 quick flexes of your pelvic floor muscles, not long, slow ones, but quick ones, boom, 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 like quick flicks. Distract yourself somehow, get on your phone, go to Instagram, call somebody, whatever. And then squeeze 5 more times, but make sure you're not rushing to the bathroom. If you're rushing to the bathroom, then all bets are off. This is not going to work. But if you're calm and you do this, then you might find that urge subsides and you've just practiced bladder retraining or bladder control. Now I'm going to shift and talk about stress incontinence. Stress incontinence is the type of leakage of urine that happens because of a lack of support underneath the urethra. So in this image, it would be right there. You see the urethra is moving, and that cough or sneeze or whatever it is has caused urine leakage to come out. So that's stress incontinence. And the treatments of stress incontinence would be, first of all, exercises. If you have very weak pelvic floor muscles and you do your Kegels for 3 months or so, you can sometimes cure yourself of stress incontinence. Also, there's certain types of pessaries that could work, and then there's surgery. The best surgery works extremely well. This is called a mesh midurethral sling, and it hit the US market in 1998, and it was quickly recognized by all of us practitioners in this world to be outstanding. This is a extremely effective, rather small operation that's done on an outpatient basis that has a very high chance of solving stress incontinence as a problem. It is made of mesh. I do this under local anesthesia with sedation. So during the actual surgery, I wake the patient up to demonstrate the leakage of urine, and I adjust the tension perfectly just for that person while they're awake in the operating room. And then, but don't feel anything because of the numbing medicine that I use. The way that the sling works is this. It's sitting there loosely. This is important because you need to be able to urinate. So if the sling is nice and loose, like it is in this picture, then you can pee, but then when you cough or sneeze, the urethra bounces against the sling itself to prevent the leakage. So this is the most effective treatment we have for stress urinary incontinence. Whenever I mention mesh, it's sort of a red flag for people. And I want to just make this point that the slings are really not controversial at all. They're considered the gold standard treatment for urinary incontinence by all of these societies, the American Urogynecologic Society, ACOG, which is obstetrics and gynecology, these other ones, these are all the organizations that have to do with taking care of women with stress incontinence, and they all fully agree that mesh midurethral slings are not only safe and effective, they're the gold standard treatment. You shouldn't get confused. Vaginal mesh is a different thing. Vaginal mesh to treat prolapse is what you hear about in terms of being controversial. If you're up on the idea that mesh is bad, it's because the FDA last year took vaginal mesh off the market because of a few problems. But remember that vaginal mesh is treating something called prolapse, which I'll get into soon. It involves making an incision in the vagina, placing a different size and shaped piece of mesh, treating a different thing for a different reason. It sits there behind the scenes and holds the prolapse up through a vaginal incision, but it's off the market, and that's not what we're talking about. Mesh slings for urinary incontinence are safe and effective. And this is our sort of latest, greatest sling. It's done through a single incision vaginally, and it's also adjusted under local anesthesia with sedation, and it's as close to pain-free as any surgery you can find. The other thing is an office procedure. If you look closely here on this slide, you'll see, I think I'll back up and show that again, because watch right here. I'm going to play this slide over again, and you'll see a scope going in and some injection of some material. This is an office procedure that we do. So here it goes. Bulking agent on either side, squishes the urethra closed. And when you're in, if you came to our office, then what we do is try to evaluate whether this is a possibility for you. Now, this is a really up and coming procedure, because there's no downtime. You come into the office and have this done and leave that same day, and it works really well. Here's the actual procedure. So this is me injecting this stuff called Bulkamid, which is think of it like a saline implant into the urethra. So I'm looking in the urethra with a scope, and I've numbed up the patient with numbing medicine. She doesn't feel this, and I'm injecting the material, which just sits there like a little water cushion or water balloon at the opening to the urethra, providing it kind of squishes it together to provide urinary continence. Okay. I said I was going to warn you before I showed you stuff like this, but then I didn't warn you, so I'm sorry about that. I'll try to remember to warn you next time in case it bothers you. Shifting gears, I'm going to talk about pelvic organ prolapse. That is basically a special kind of hernia that only women can have through the vagina. The number one thing to remember about prolapse is if it doesn't bother you, you shouldn't bother it. In other words, it only matters if it's giving you symptoms. So if a gynecologist saw you and said, it looks like your bladder is starting to drop, but you were unaware of it, then it doesn't matter. It's good to know, I guess, but it doesn't need any sort of treatment. So never fix or submit yourself to surgery for a problem that's not actually bothering you. So if your anatomy's like this and everything's up where it belongs, then you wouldn't feel any prolapse. And if your anatomy is like this, where you've got a bulge of the bladder and a bulge of the rectum, but they're not coming out through the opening of the vagina, you might feel the same. So women with these two types of anatomy might feel the same as each other. But if it starts to come out, that's when people get symptoms. Symptoms they get would be like a heavy bulging pressure sensation, or feeling like something's rubbing on your clothes, or you're sitting on a ball. And the bulge can be the size of a walnut or an egg or a lemon or even a grapefruit. And we always ask these questions before we examine patients to make sure that I'm able to duplicate the examination, what they're seeing in their day-to-day life. The non-surgical treatment that's been around for ages, literally millennia, is a Pessary. So this is the medical version. It's medical grade silicone, but people used to use things like pomegranates back in ancient Greece. But a Pessary fits inside the vagina and just sits there holding the prolapse up. I'm going to back up and show this slide again so you can watch. This is the Pessary going in. I can very often take somebody with prolapse and they're very uncomfortable, and we say, do you want to try a Pessary? And they say yes, and we put it in, and all of a sudden they've got instant relief. And Pessaries can be a nuisance. You have to learn how to remove it and clean it and put it back in yourself. Or if you can't do that, then you come to the office periodically to have it cleaned. But it's a nice non-surgical option for people. So what are we treating if we're doing surgery? It's usually something like this. A cystocele would be a dropped bladder, which is like that. So here you see everything up where it belongs with the bladder and the uterus up there. And here's prolapse where the bladder is bulging out, feels like a water balloon, and the uterus is right behind. Or there's something called a rectocele, which is when you get this kind of a bulge. Instead of the rectum being in its normal position here, you get this bulge out. And you might feel this especially during a bowel movement, or maybe even all the time. It can be very uncomfortable. And then there's uterine prolapse, where the uterus comes down like this. Excuse me. So normal prolapse. This is an example of kind of the worst sort of prolapse, where everything's coming down, because it's not just the uterus, it's the bladder and the rectum also. My favorite way when I'm doing surgery for these problems is to use something called the daVinci robot, which is just a fancy laparoscopic tool that allows me to sit down at this console and use the controllers and use the 3D magnified visualization and do the surgery that way. And It's highly effective. There's a decision tree when we're deciding on surgery. The first decision is, are we going to do a reconstruction, which is almost always what we do, or is it going to be something called an obliterative procedure? This is something that's an option that's open to women who maybe think that there's no chance that they can have a safe surgery. I'm talking about somebody who's gotten much older, they're in their 80s or maybe even 90s, really bothered by prolapse, but a great big operation is not something that would maybe be safe. We can still do these things called obliterative operations, because that's literally just closing the front of the vagina to the back of the vagina and keeping the prolapse symptoms away that way. Of course, most people don't want that because it prevents sexual relations, but when that's not a factor, this can be an option for people who were told otherwise that they couldn't have an operation. This is about maybe 5 or 10% of what we do, and about 90% to 95% is a reconstruction when we're going to the operating room. The next decision, if we're going to do a reconstruction, is whether it should be what we call native tissue versus using a graft. So native tissue is like this. I use the tissue that's in the body already to do the repair. And this is the classic way that I was trained, and this is how I practiced mostly for years. But of course, the problem, if you think about it, when we're doing a native tissue repair, is the repair is only as good as the tissue that we have to work with. And we don't really know whether it's going to be good or bad tissue until we get in there. And once you've started on the pathway of doing this surgery, you can't really change in midstream and put a graft in. It has to be sort of one or the other. So the success rate or failure rate, however you look at it, of this operation is about 50-50. So about 50% of the native tissue repairs work well for a long time, and about 50% of them fail in the first year or so. This is just an example of what's called a bladder tuck or a bladder repair. And then with using native tissue. Now this is graft augmentation that I'm going to show you next. And if you do get queasy looking at surgical type videos, then maybe don't look at some of these slides I'm going to show next. But the operation that works the very best is, again, using a lightweight mesh material. It's called a Sacrocolpopexy. And the mesh is very lightweight. And if you have a uterus, then I tend to do a partial hysterectomy, removing this part of the uterus, but leaving the cervix, and sewing the mesh to both sides, and then sewing the other end of the mesh to a ligament in the pelvis. And this is the same operation if a patient comes to me having had a hysterectomy in the past with prolapse, then it sort of looks roughly like this operation. And here, I think the next slide is the video. Nope. Teaser. Not. Maybe the next one after that. This is the incisions that we use. So this surgery takes a couple of hours to do, and there's 5 incisions, and it's not pain-free, but but most patients don't use any narcotics at all. I did one of these yesterday, and the patient went home today by 11 o'clock, urinating well, and had no need for any narcotics at all after the surgery, and that's very common. So here's the robotic surgery. So these are the robotic arms that I control. These instruments are tiny. They're less than a centimeter in length. And this suture material that I'm using here is made of Gore-Tex or polytetrafluoroethylene is the chemical name. And using these fine instruments, I'm able to do the surgery through really tiny incisions to make the pain as small as possible. And these are the incisions that I use to fasten the mesh to the ligament in the pelvis. So take great care to do everything in a real precise fashion. And you can see there's not, maybe when you heard surgical video, you were thinking about a lot of blood, but there's almost no blood loss during these operations. And then this is the way to pull it down, and then we secure those knots with a lot more knot tying, and that's the surgery. And the finished product, the reason that mesh is not an issue is because we cover the mesh with this stuff called peritoneum, and so the mesh is sort of behind the scenes. It's like nothing ever happened. We do the fix and then put it back behind this peritoneum, and then it's sort of like the body, the bowels, the other organs can't really have contact with the mesh material, which is why it's so safe. All right, I've covered a lot of things pretty quickly. The summary of our practice, and I think it should be anybody's practice in urogynecology, no matter where you go. Non-surgical options should be offered first and often, but if it does come to surgery, there's minimally invasive approaches that are evidence-based. And I'm seeing a few questions, or at least I'm not seeing the questions actually. I'm just seeing the fact that there are questions. So I'd be very happy. We have plenty of time to answer questions if someone wants to maybe read those to me.
Thank you so much, Dr. Culligan. That was wonderful. So just a couple of questions. Is there if like weight gain or loss after the procedure, sling procedure, would that affect the effectiveness of that, or such a
Not really. So the way this plays in is if someone's very overweight, then losing weight can make urine leakage better. However, the scenario that I see often is someone might be very overweight, but it's hard for them to incorporate exercise into their weight loss plan if they're leaking. So I've often placed slings in patients who are very overweight, and it can be sort of the first great step towards losing weight because and I've seen tremendous weight loss after a sling was placed, and it doesn't change the effectiveness of the sling itself. And it can be a motivator, right? So I've had this surgery, now I don't leak, now I have no excuse. I better, incorporate some exercise, even if it's just walking, into the weight loss regimen, and so that can be motivating.
Great, thank you. Another question is, if a woman has a pessary inserted, is it still recommended to do the Kegels to strengthen the muscles so they don't further weaken?
Great question. By the time somebody needs a pessary, usually they're not going to have a huge impact on the prolapse by doing Kegel exercises. So it certainly wouldn't harm anything to do it, but it probably wouldn't help either.
Okay, great. Somebody had asked, is there a webinar that for this common disconnect of the muscles and all the medical issues surrounding it from a C-section type delivery? Is that at all connected at all? So that's what somebody had asked.
Yeah, so I think maybe what you're getting at is if everybody had a C-section before labor, would that put me out of a job? And the answer is not me, but maybe the next generation. It would work towards that. I'm not saying everybody should have C-sections at all. Obviously, that's not right. What I do think is it would be wonderful if we could do the kind of research that would be required to determine who's going to have the big problem. And because since vaginal delivery is the common denominator between most of these things, what I'd like to see and what I've kind of looked at through some of my research over the years is trying to predict which women are at risk, and then at least offer them the option of doing an elective C-section rather than have a baby vaginally, if that makes sense. And right now, we're not light years away from being able to make those predictions, but we're not right about to do it either. And so, sometimes if a baby gets really big, we can say, ooh, that's going to be a rough delivery, and maybe offer an elective C-section. But right now, if a woman wants to have an elective C-section because she's worried about urinary incontinence or prolapse or fecal incontinence, it's her right to do that. And the advice typically would be, if you're going to have one baby, then probably that risk-benefit ratio makes good sense. If you're going to have two babies, probably makes good sense because that's not a ton of trauma to the uterus. If you're going to have three or more babies, or you're not sure, then that starts to get riskier for a variety of reasons. So I hope that answers the question. It's a matter of hot debate in our world.
Okay, thank you so much. There's a question here. I hope it makes sense to you. How long does bulking the urethra last?
That's a great question. So it lasts for some people, probably a third of people, like 30% or so, it'll be a long-term thing, longer than 5 years that it lasts. This is extrapolating from other data that I know. Most people need kind of a touch-up injection within about a year. And we don't have the careful kind of research to to give you better information than I just gave you. That's kind of the summary from all the research that's been done so far.
Oh, great. Couple more, if that's okay, Doctor.
Sure. Yeah.
Does colonization cause urgency, would you say?
So I think the question has to do with maybe somebody that has bacteria, so bacteria living or colonizing inside of the bladder, and that is something that I think can be the case. So there's a classification of patients that are thought of as having asymptomatic bacteria, which is bacteria growing in the bladder that aren't producing any symptoms. One way to sort that out is to give antibiotics, and let's see if that overactive bladder or urgency goes away. If it does, then maybe that wasn't asymptomatic after all. Maybe it was symptomatic, and it's a low-grade infection and it needs cure or treatment. And so we see some patients in this regard, but usually we have a colleague here at Valley who's our go-to person when it comes to chronic urinary tract infection type issues. So usually we're referring to that doctor.
Okay, great. So a couple questions about Kegels. Somebody said that her gynecologist stated that there is electronic equipment that is like Kegels. Is that an option to assist?
Yes. The best one of those products, I think, is it's called the Leva, L-E-V-A device from a company called Renovia, and it's expensive. It costs about $600, and it's not paid for by an insurance company. So if you have one of those medical accounts at work, then it would be covered under that. But otherwise, it'd be an out-of-pocket expense. But it's sort of like super Kegels, because you put this little soft sensor in the vagina, and that sensor hooks to your smartphone. And when you're doing a squeeze properly, then you can tell because this little needle moves and deflects the proper way and shows how strong you're getting. And by the same token, if you're doing the muscle contraction incorrectly, it'll show you that. So that's biofeedback for Kegels. And then that same device, not the same device, but another product that comes with that device is an electronic stimulation device, which is just that. It's a little probe that hooks to a pulse generator, and it sends an electronic impulse to the Kegel muscles to have them relax. It's sort of like you see those things on TV, like the ab muscle belts, and they're contracting the muscles for you, and that's what this thing does. It's called electrical stimulation. We don't know how well that works, by the way. It's been studied a lot, and it's sort of up in the air whether it really helps.
Okay, just one more about Kegels. Do Kegels help if one already has a prolapse about the size of a small lemon? Would that help, or?
No. At that point, there's no way you're going to Kegel your way back to having the bulge go up inside. So it's either going to be prolapse surgery or a pessary. And I do think it's helpful to go to physical therapy and relearn how to do Kegel contractions after surgery. Some people, it's very important to do that. And so spending a lot of time on that before surgery, if your bulge is already the size of a lemon, that's it's not going to help.
Okay, and just one more question, if that's okay.
Sure.
Someone says here, I have interstitial cystitis and would like to hear about it. Is there any surgery for that? Could you comment on that at all?
Sure, I'll comment. This isn't my area of real expertise, but it's a condition. I see it. I can help diagnose it, and then I typically refer those patients to someone who takes care of almost only interstitial cystitis, because this is an area that's there's a lot of frontiers of surgery, not surgery, excuse me, that's not right. Frontiers of treatment going on and research. So interstitial cystitis is poorly understood, but what it means is, the other terminology is painful bladder syndrome. And so in the wall of the bladder, there's some malfunction of the nerve fibers causing them to create pain and an urgent feeling to urinate. And it can be very severe, and it wouldn't have anything to do with infection or even how much was in the bladder. And when this is the case, women usually have had lots of treatments for urinary tract infections that weren't really infections, and eventually get fed up, and somebody along the way figures out that maybe that's what they've got. And then there's various bladder installation treatments. We don't offer those, but we can send patients for those. Or there's sometimes medications. There's not much surgery. Surgery is not really an answer for the interstitial cystitis patients. And again, I rely on some of my colleagues who focus strictly on that. So I'm kind of a starting point, but not a final destination when it comes to interstitial cystitis.
Oh, thank you. And just one more question. Actually, this really is the final one. If you have prolapse involving all three organs, will a pessary help, or would surgery be the only option for that issue?
It can. It all matters based on how big the opening to the vagina has become, and how much muscle there is left. So yeah, stage 4 prolapse, if I have the right kind of pessary and the right kind of patient for it, we can give them relief with a pessary. So it's harder, and we might have to go through different iterations in the fitting process, but we can oftentimes find one. And yeah, so that's the best answer to that. The nice thing about a pessary is if you try it and it doesn't work out, all you've lost is a little bit of time. There's no other, complications from that if you're doing things like we say.
Oh, great. Oh, wow. Thank you so much, Dr. Culligan. This was excellent. Really was great presentation.